press 2 to decline and stay muted. And/or transcribe.
Sorry, can you hear me? I'm having a little issue with my technology. Okay. Today's July 8th, 2026. I'll call to order the Green Mountain Care Board's hearing. We have a number of agenda items. We have first the 5 hospital budget enforcement and a potential vote. We also have AHS's 2026 Healthcare Workforce Development Strategic Plan. Next, we have AHS's hospital transformation update. And lastly, we have Data Governance Council Submitter Communication, SOP. First, I'll take up the meeting minutes from June 15th, and I move for approval of those minutes.
I'll second.
All in favor of approval, say aye.
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 Aye. June 15th is approved. Next, I move for approval of the meeting minutes from June 17th.
I'll second.
All in favor, say aye.
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 Aye. The minutes are approved. Next, I'll turn to our Director of Health Systems Finance, Matt Sutter, to update us as to where we are on the fiscal year 25 hospital budget enforcement.
Thank you, Chair Foster. Give me one moment to get the handful of slides we have pulled up. We did want to briefly mention, I think at the staff's recommendation around, I think I just lost control here. Let me reshare the slides, I think. So at the last meeting, there was staff recommended that we did not enforce on North Country's overage. Just as a reminder, their overage was due to revenue from an FY 21 to 23 amended cost reports being recognized in 25, rather than an overage specifically related to FY 25 performance. So while staff does not recommend correcting for that overage through budget enforcement, we do think it's appropriate to consider their full revenues and amended cost reports during the hospital budget review process as we review the FY 27 submission. And we just also wanted just to cite the language in statute requiring that individual hospital budgets shall reflect budget performance for prior years, and if not already addressed pursuant to the enforcement process, account for any significant deviation in revenue during the most recently completed fiscal year in excess of the budget established for the hospital pursuant to this section. So we believe it was more appropriate to consider kind of holistically with their whole budget submission than how we've traditionally handled enforcement related to single year performance. But we did just want to close the loop on that piece in this meeting. We have developed a couple of staff recommended options for CVMC enforcement. The option 1 is to decline to enforce their FY 25 NPR overage, which would require no motion if the board elected to go that way, or to enforce on the major commercial overage of $2.239 million, effectuated as a commensurate reduction in the hospital's commercial reimbursement rate for FY 27. So Chair Foster, we do have some potential motion language here if that's the avenue the board would like to go down, but I turn it back to you for board deliberation.
Thank you. And my own assessment of this under our guidelines and the factors that we're to consider is that this is a very difficult consideration. The overage was significantly higher than the $2 million commercial enforcement that staff suggested would be a possibility. So in some levels, there's a fairness to including an enforcement just of that portion of the overall overage. At the same time, CVMC's financials are really difficult. They took some steps to self-correct mid-year, which was beneficial, and it's going to be hard for them to absorb a further rate reduction as a result of an enforcement. So I personally see this one as very difficult, and I'm interested in hearing from the other board members. So I will call on the other board members to hear their perspectives, and I'll go in reverse seniority. So I'll start with member Teachout.
Great. Thank you, Chair Foster. I agree there are some difficult aspects to this decision, but I am in support of the second option. And I have a couple slides, if you don't mind, I'd like to show just to explain some of my thinking behind this.
Please do, that'd be really helpful.
Okay, so I will. That's kind of interesting. Okay. I'm not sure I can make it bigger, but so sorry, I can't make it any bigger.
For us, it's full screen. It looks great.
Okay, great. So one of the things that I was considering in looking at this is what the drivers were behind CVMC's overage. This is one of a bunch of different documents that were shared with us. I believe this one was available to be public, and it shows that major imaging and some of the minor imaging are a big driver behind the revenues that were above what was projected. And this was just year to date of the hospital's budgeted amount versus actual amounts. And you can see that CT scans just in this one time period were, and again, it's really small, but a double-digit overage. So that is one of the considerations. The other thing with this slide is that CT scans at CVMC increased 31% between FY22 and FY25. And then there was some information from the hospital about prior authorization, protecting patients from additional unnecessary care. And I would note the imaging ordered by the ED does not have any prior authorization, which is 40% of the CTs, and imaging ordered by primary care physician does not have prior authorization. There was no information about how much of that was the total. But my point there is that prior authorization is a minimal tool for checking unnecessary imaging. The next slide is from our price transparency tool. This is FY25 VCures data, and it shows you as a percent of Medicare, and it's the Green Mountain Care Board's definition. So for the percent of Medicare, a standard X-ray at CVMC in FY25 was over 600% of the Medicare price. Ultrasound is 519%, CT scans are over 1,000%, MRI is over 550%, and nuclear medicine was about 345% of the Medicare price. So you can see from this that the prices for these services, commercial prices, are quite high. The point that I would make there is that when commercial CT scan prices are over 1,000% of Medicare and there are significant volume increases, the responsible action is to lower prices. And the next slide is specific to CT scans. And this is the growth over time. And I couldn't get the labels on here, but the orange bar is CT scans, the growth of the price as a percent of Medicare. So I wanted to share that. I do understand that the financial condition of the hospital is a consideration when looking at enforcement. This was information provided by the hospital on their operating margin. And you can see that it certainly has not been great over the last number of years. But I would also point out that until very recently, the operating expense growth was also extremely high and not in check. The one thing that I did ask our hospital finance team to look at was if this option 2 was to go into effect for fiscal year 27, what the impact would be on their operating margin. Their budget as submitted has a negative 1% operating margin. It would increase it by 0.6%. So it would be negative 1.6% in FY25 if this was to be approved. And so again, looking at all of the pieces of the overage, I have focused only on the major commercial, which is a small or a partial amount of the overage, the 2.2 million, in consideration of their financial condition, but also wanting to correct for the overage that has to do with imaging, among other things. So let me pull my slide down. I need to unshare. Shoot. Yeah, trying very hard. Stop sharing. I got it. Okay. Thank you. I'm proposing the partial enforcement in consideration of the hospital's financial results. At the same time, it's clear from the information submitted and the data from ViaCures that there are very high outpatient commercial prices, particularly on imaging, along with increased utilization, some associated with the stroke center certification that's driving the FY25 overages. That's all I have to say. I'll let you move it to the other board member.
Thank you very much. Member Walsh.
Thank you, Chair, and thank you, Member Teachout, for the excellent analysis. I don't have slides, but in reviewing the submissions and the requirements for an option of enforcement, I too was drawn to the fact that CT scans increased roughly 31%. And we were, the explanation for that was increased need. So I tried to look at where else have we seen increased need. If patients in the community are sicker and are needing more services, we should see evidence of more utilization elsewhere. I saw a 10% increase in ED visits over the budget period, but no other substantial increase. It's hard to take on face value that only patient need is driving the increased utilization of CT scans at CVMC. And as Sarah pointed out so nicely, that is one of the highest priced diagnostic tests relative to Medicare. I think foregoing enforcement when an overage is due in part on operational decisions, not real patient need, that's just not something that I'm comfortable with. I do understand CVMC is in difficult financial positions, but that alone, I don't think should cause us to forego enforcement, particularly with this pattern that we're seeing. So I too am in agreement. I'd support option 2 from the staff's presented options.
Thank you. And Member Holmes.
Hi, good to see you all. I guess at this point, I would say I really appreciate Sarah's really thoughtful analysis around the imaging prices and the volume, and I agree that the prices in particular are problematic. Although I always worry about looking at individual prices in isolation. But I think I'm not quite ready to enforce the 2 million. I'm open to hearing more discussion about this. I fully recognize and appreciate the importance of ensuring that our hospitals adhere to the budgets that we approve, right? That's really important. But I am really concerned about CVMC's pretty precarious financial position, its long-term sustainability, and its continued ability to provide high-quality patient care. For most of my time, on this board, CVMC has been unable to generate a positive operating margin, right? And I think, Sarah, your slide showed this. I've looked at it. In recent years, operating losses have hit $17 to $18 million. And that's actually despite financial support from the network over the years. And I think, as we all know, persistent financial losses of this magnitude have huge impacts on a hospital's ability to make long-term capital investments that are necessary to, maintain, improve their facilities, keep up with technology, all the things that we know that having a margin allows a hospital to do, and ultimately to provide that high quality patient care. I'm going to add this fact to this. CVMC has gone from a Medicare rated 5-star hospital in 2022 to a 3-star rated hospital today. And fiscal year 22 and 23 were among the worst years that they've had financially. Correlation, we know, is not causation, but the parallel trajectory of large financial losses coupled with quality decline is worth noting here. Fiscal year 24 was the one year in about a decade, and at least in my recent memory, that CVMC was able to generate a positive operating margin. And that largely was due to a commercial NPR overage. And that we enforced half of that overage, and we applied an 8.6% reduction to their commercial rates for fiscal year 26. That's also one of the largest enforced reductions that I can remember on a hospital that generally overall, I recognize some of those prices on imaging and radiology are high, but generally overall, the general prices at CVMC are low to mid-level in the state, high nationally, but lower to middle range in the state. And that enforced rate reduction is still working its way through this year's financials. And through quarter 2 of this financial year, or this fiscal year, their days cash on hand are well under budget. I think they're around 70 instead of the 80 that was projected, and 70 is not great. And their operating losses for this year are already at 7 million, and they're projected to be closer to 8 million by the end of the year. So fiscal year 26 is going to be, if things keep going in the direction that they're going, one of their worst in the decade. Not quite as bad, perhaps, as those $18 million losses, but top 3 anyway. So they're already incentivized to cut costs. And with the financial headwinds that are coming our way with this one big, beautiful bill, I think the incentive to streamline and cut costs are greater than ever. They're already budgeting an operating loss for fiscal year 27. Enforcing this further weight reduction right now is either going to generate greater financial losses for the hospital or accelerate expense reductions that have to happen anyway. But I worry that if they're done too quickly, may compromise patient access and quality. So I'm in a place where I'm looking at the financial situation and feel as though I would prefer to option 1 in this particular regard. But putting them on a watch list, so to speak, particularly as we go into the hospital budgets. That's where I'm at, Chair Foster.
One question, and Member Holmes alluded to this, like there are particular prices that Member Teachout pointed out that are egregious. Like they're really not acceptable. And I think Member Holmes is right. My information is on the aggregate. Their prices by Vermont standards, at least, are not on the higher end. However, looking at them individualized matters for those individual patients. And it would be much more equitable for those prices and for CVMC to make the financial impact it needs on its budget if the prices were more fairly distributed across service lines so that it's not so heavily weighted, because it really does matter to the patients who are getting coinsurance to have prices that high, paying coinsurance. So just as a note, I mean, for any hospital, we really don't want to see price jacked on to one particular service line or another. It is incredibly unfair to those patients, and we need to correct that here in Vermont. So I guess my question is whether it's Member Teachout or maybe Mr. Sutter has the information, but what is our best understanding of how CVMC's prices compare overall nationally and here within Vermont, if anyone has that available?
I can add from the OnPoint price transparency tool we have. They're sort of in the middle range, to middle to lower range, but kind of in that cohort around. I don't want to speak extemporaneously about the percentage, but I think of that's sort of median to low median range.
For Vermont or nationally?
For Vermont, I'm not sure about national.
Chair Foster, I can try and pull it up, but I don't think I'll be speedy.
That's okay. Mr. Sutter, I hate to ask you or one of your staff members to do it on the fly, but if you could just touch base with one of your staff members to see what the best information is that could be available. Or if CVMC has that information available, I think it would be helpful to look at both the individual prices that Member Teachout pointed out and the overall cost structure of the hospital commercially. And this is the challenging part of the job, right? I mean, the reality is the math doesn't work. The math doesn't work for CVMC. The math doesn't work for patients paying commercial insurance. And this is the bind that we're in. If we make one decision to enforce on CVMC, Member Holmes is right. This is very, very difficult for them financially to absorb. And to Member Walsh and Teachout's point, likewise, these commercial insurance patients can't pay it either. And this is just sort of the rub that I find ourselves in routinely right now here in healthcare, is there's no right answer. If you don't enforce on CVMC, it's better for CVMC and arguably a lot worse for the patients that are paying these enormous amounts for particular services. There's no clean or good answer on this. I myself I could vote either way, to be honest. I don't know that there's a right or wrong answer. I think the best way to kind of work through this is to try and make motions and see where people land. And I have a sense of what the first motion would be in the outcome, but why don't we go ahead and try that? Member Teachout, if you wouldn't mind, if you would like to make the motion on your suggestion, we can go that route.
Sure, thank you. I will make the motion, and I would note that mine is slightly different than what staff put on the slide, and I can explain my difference there.
Great.
But I would move to make a finding that Central Vermont Medical Center's performance differed substantially from its FY25 budget, and to partially enforce this deviation by reducing its FY27 commercial NPR by $2,239,750 from the eventually adopted budget, and require Central Vermont Medical Center to effectuate this commercial NPR reduction through, and this is where it's different, lowering its outpatient commercial reimbursement rates, and to provide documentation to the Green Mountain Care Board demonstrating how this is applied. So my preference is to target it where the prices are very high.
Is there a second?
Yep.
Okay. I'll turn to the healthcare advocate for any comment on the motion.
Yep, this is Sam Peisch. I don't know if I'm off video yet. Okay. Good to see all of you. It's been a little while. I think it'll come as no surprise that the HCA, we support full enforcement generally for a number of reasons, particularly the precedent of the board and I think the legitimacy of the board to a certain extent. I have a lot of empathy for all of you reckoning with all the different challenges here. Given that that's not really a motion on the table, I think we would support Member Teachout's motion. I think it makes sense. But I question the value really of a lot of these budget orders if they're not enforced. I think the hospital budget process, you all do a really rigorous and deep dive into all the different intricacies, and then you enact budget orders that are very clearly articulated. And it's a little bit hard for the HCA to understand these different contending factors after the fact when it's clear that the finding has been identified that a hospital has gone over a budget. So there's that disregard, and this is far beyond that. So, but thanks for taking the time to consider our thoughts, and good to see all of you.
Thank you, Mr. Peisch. And for what it's worth, I totally agree. Why go through this extensive budgeting process that's laborious and expensive for everyone if the budgets don't mean what they say? At the same time, we have established procedure and precedent on how we handle situations where they do go over. And I think, in my hindsight, I'm well willing to admit when I think we've made mistakes, but our enforcement decisions, I think the last several years, in hindsight to me, have been spot on. When we've enforced in full, to my opinion, it was correct. And when we chose not to, it was correct. And we did partial, I think it was correct. And the process is meant to allow for situations where there might be changed circumstances that dictate it. So we are trying to get that, but I do agree with the sentiment. The orders have to matter, or why are we doing this? I'll open up to any public comment. Okay, and I'll take a roll call vote. I'll do the roll call vote myself, unless I'll just do it myself. I'll go in order of seniority. Member Holmes.
No.
Member Walsh.
Yes.
Teach Out,
Yes.
and I am a nay. I'm going to make a different motion myself. Let me see if I can figure out what it is. I move to make a finding that Central Vermont Medical Center's performance differed substantially from its FY25 budget, and to enforce this deviation by reducing its FY27 commercial NPR by $1,119,875 from the eventual adopted budget, and requiring CVMC to provide documentation to the GMCB on how it will effectuate this commercial NPR reduction through changes to its highest price commercial reimbursed services. I'll stop there and explain the difference in my motion. One is I'm moving to enforce 50% of the commercial NPR overage versus member Teach Out's full enforcement. And then second, like member Teach Out, I think it would be equitable and consistent with Vermont law to use that commercial enforcement on the highest price services so that patients have greater fairness in the prices for services they receive.
May I ask a question about your proposal, Owen?
Please.
When you say highest price, I'm assuming you mean relative, or do you mean absolute? When I think of relative, I mean relative to Medicare, relative to something. So
Relative to Medicare, their highest price commercially reimbursed services relative to Medicare.
Okay.
I'll second your motion, Owen.
Thank you. Additional board member questions or discussion? Okay, and as part of any motion, we need to take public comment and hear from the HCA. I'll turn to the HCA for any comment on this motion.
I think it's a good suggestion. Reminds me of being on the select board trying to find consensus, so makes sense.
Thank you. And I'll open it up to public comment. Ms. Patnode, I'll just identify you. You're the CFO of CVMC. Thank you for being here. Thank you for raising your hand to help us consider the motion.
Thank you. Thank you very much to all the members. This is not an easy task upon any one of the four of you, but thank you. I do want to remind our board members of the impact of Act 55 that does also come into play for fiscal year 2026. That is about a $2 million increased reduction in our net patient revenues for pharmaceuticals. So I just would be remiss if we forgot about Act 55 during your deliberations and your considerations. There are already seeing an additional $2 million reduction in what we turned in for our 26 budget. Thank you.
Thank you. That's a good point. Kind of one other thought that came to my mind when Ms. Patton was speaking was also, we know we have these financial pressures across the entire hospital system. And part of our consideration, I think, with this and the budgets that we're going to be reviewing is where is the right level of pressure? Where is the right reduction to be targeted? And I think Member Holmes made that point in recognizing CVMC's overall prices and also financial situation. We're looking for pockets of places where we can appropriately reduce price without having too much disruption. At the same time, there's going to be financial pressure on the system. Walter Carpenter.
Thanks, Owen. Can you hear me all right?
Yes, sir.
Thanks, Owen. I just have a lot of trouble understanding how, with prices so high, thanks to Sarah's presentation and graph, how CVMC is in such straits. But I guess that's just a layperson's point of view.
It's a fair point. I mean, we're seeing this really across many Vermont hospitals, and really we've sustained our hospitals as they have been in the status quo due to really, really high prices on outpatient drugs and frankly on outpatient services, and Vermonters just can't afford it. So the reality is, like I said before, the math doesn't work, and that's where we're at. There can be a whole host of reasons, cost to operating the hospital, infrastructure needs. CVMC's got a very, very old age of plant, labor costs, travelers, locums, all of it. It's a Medicaid reimbursements. There's a whole host of challenges that I do think play on their finances and make it very difficult. Any other public comment? Okay. All right, I will go for a roll call vote as well. Again, we do these in the order of seniority. Member Holmes.
In the spirit of compromise, I will be a yay.
Thank you. Member Walsh.
Similarly, yes.
Member Teachout.
Yes.
And I myself am also a yes. So the motion is approved. I want to thank CVMC for how they presented this overage and how they dealt with this issue. My perspective since I've been here, that was the most collaborative and thoughtful and beneficial approach to this, and it really did have an impact on me and I think the other board members. So I want to thank you for that. We do recognize the financial trouble. We wish there's more commercial money to go around, but we thank you for how you dealt with this very professionally. I also want to thank the staff and the board members for all being very open-minded that this is a hard one, and I'm glad that we're able to get to a resolution that we can all live with. So I want to thank the board members. Okay, moving along, our next agenda item is the AHS 2026 Healthcare Workforce Development Strategic Plan. I'll turn to Hillary Watson.
Great. Thank you, Chair Foster and members of the board. Thank you, Ellie, for bringing up the slides. Can folks see the slides okay and hear me okay?
Yes.
Great. All right, as mentioned, I am Hillary Watson, a project director for quality access and planning on the policy team here at the board. And I have been one of the staff members working with our partners over at the Agency of Human Services to coordinate the board's review of their healthcare workforce development strategic plan. So I just have a few grounding slides to run through, and then I'll turn it over to Ellie Cady, one of our policy analysts, for an overview of the board's review activities and the timeline. Then after our brief intro, we'll hand it back to you, Chair Foster, to welcome our colleagues at the Agency of Human Services who will be sharing an overview of the plan today. So next slide. Thank you, Ellie. I just wanted to start by providing a brief summary of both the agency's and the board's statutory responsibilities around this strategic plan. So 18 VSA 9491 requires the Director of Healthcare Reform in the Agency of Human Services to maintain a current healthcare workforce development strategic plan. This stems from Act 48 of 2011, which required the Director of Healthcare Reform to develop a strategic approach to addressing workforce needs and ensuring an adequate healthcare workforce to provide care for all Vermonters. So Act 155 of 2020 then evolved this requirement. Act 155 was an act related to increasing the supply of nurses and primary care providers in Vermont. And it established that the Director of Healthcare Reform maintain a current healthcare workforce development strategic plan that continues the effort to ensure that the state has the workforce necessary to provide care to all Vermonters. So then on the board's side, 18 VSA 9375 details the duties of the board. One, as detailed in subsection B3, is to review and approve the healthcare workforce development strategic plan, which is why we are here today. So next, just for easy reference and access, we wanted to provide links to the Agency of Human Services Healthcare Workforce Development webpage. So AHS actively maintains this page, and it is where you can find both the 2021 and the 2026 strategic plans, as well as information about the advisory committee that works with the Director of Healthcare Workforce to develop and maintain the strategic plan. So now I will turn it over to Ellie, who has been coordinating this process along with me.
Thank you, Hillary. Hi, everyone. My name is Ellie Cady, and I'm a policy analyst on the Quality Access and Planning team. I'm just going to share a little bit more detail on the timeline for GMCB's review and approval of the plan. So GMCB is moving through a similar review and approval process as was carried out in 2021. So on April 16th, AHS submitted the plan to the board for review and approval. And today, July 8th, AHS will present an overview of the plan to the board. This past Monday, July 6th through next Tuesday, July 14th, GMCB has opened a public comment period. Members of the public and GMCB's General Advisory Committee are welcome to submit public comments about the plan at this time. And feedback from that public comment period will be summarized for the board next Wednesday, July 15th, where the board will then deliberate and vote on approval of the plan. And with that, I will hand it back over to Chair Foster. Thank you.
Thank you very much, Ms. Katie, and welcome. This is your first time presenting to the board. So while brief, I thought it was excellent, and we really look forward to having you present more. You've been a wonderful addition to our team, so thank you.
Thank you.
I will turn it to Ms. Olson. Jill Olson is the, I forget what title you have, Jill, because you have so many roles that you play. I actually don't know what your title is because you do it all. But thank you for being here, and I'll let you introduce yourself.
All right. Can you guys hear me?
Yes.
Okay, we're now having some echoes, so I need to fix that. I can hear myself through your, yes, can you turn it off? Yeah, so if you guys can hold on one second, we are all in the same room together, and I just want us to sync up on how we're going to do this. Apologies. Yeah. Okay. Now I'm echoing.
Yep. I'll mute it. So whoever.
There we go. Try again.
Yeah.
Can you hear me?
Yes, that
Okay,
sounds
sorry
great.
about that. That was really hard. Again, I'm Jill Olson, and I am the, oh, now you can't see my camera. Let's fix that. I am the Vermont Medicaid and Health Systems Director. So in my role, I serve the Secretary. I report directly to the Secretary of the Agency of Human Services, and I have broad responsibility for healthcare reform and Medicaid. So it is a pretty broad portfolio. I'm really here today to introduce you to our team. And so for the Workforce Strategic Plan, we have, actually, I'm going to start with Julio. We have a new Director of Healthcare Reform who you have not yet met. So I'm just going to let Julio introduce himself briefly. And then I'm going to turn it over to Suzanne Tremblay, who is actually the person who has done all of the homework on this plan. So let's start with Julio.
Hi, everyone. Julio Cespedes with the Office of Healthcare Reform. Very excited to be part of the great work that this board is doing. I'm a biomedical engineer by training and originally from Mississippi, another very rural state with high needs and with a lot of hospitals that were also in very critical financial conditions. And so I'm looking forward to just working with all of you and really helping all this great work that we're trying to do for the state of Vermont. So very nice to meet all of you.
Thanks, Julio. And I'm going to turn it over to Suzanne, let her introduce herself, and then jump in to our presentation.
Hi, everyone. My name is Suzanne Tremblay. I'm the Healthcare Workforce Director in the Office of Healthcare Reform, and I'm excited to be here today. I started with the state in 2024 and have been working diligently with the Strategic Plan Advisory Committee to present this work to you today. So I look forward to doing so. Anything else before I begin? Just going to share my screen and make sure everyone can see it.
Looks great, Susan. It's good.
Okay, perfect. All right, so hello, everyone, and thank you for having us today. As mentioned earlier, when Hillary was talking, we are here to present to you and discuss our updated healthcare workforce development strategic plan and its development. Ultimately, for your approval as mandated, as we know, under legislation, but more importantly, to further align our collaborative efforts toward accessible, high-quality, affordable care. As we are all aware, I'm sure, ensuring Vermont has a stable and adaptable healthcare workforce that evolves to meet the state's changing needs is essential to the equation. Our agenda today will be to provide some context and landscape behind the establishment of the plan, to review the strategic goals and the initiatives and how they came to be, to talk next steps and field any questions you may have. The updated plan reflects extensive stakeholder engagement, consensus building, iterative updates in response to actively gleaned feedback. It reflects Vermont's healthcare landscape, trends, and Vermont's priorities. It's an actionable, forward-thinking roadmap that is meant to set the stage for the broader work related to Act 68 of 2025, specifically the Healthcare Delivery Strategic Plan, and in the creation of long-term strategy and other initiatives. It supports alignment across a multitude of statewide initiatives and collaboration across the systems that are all involved. The process was collaborative and it was led by me, the healthcare workforce director. But it was developed primarily by the Healthcare Workforce Development Advisory Group, established under legislation in 2020, I believe, under some of the same statutory rules that we just reviewed. And it was reviewed for feedback and approvals by the Vermont Department of Labor, the Office of Workforce Strategy and Development, AHS Leadership, and the chair of the State Workforce Development Board. I want to touch briefly on what we know and have here in Vermont already. We have a mental health workforce shortage, housing and transportation barriers, wage disparities. We know that working age adults are our biggest group of people moving and staying here in Vermont. We know that data is beginning to show that our recruitment and incentive programs are retaining talent across the healthcare spectrum. Our institutions of higher education have significantly increased enrollment. This past year, VTSU opened up more nursing slots at their Johnson location, and we are almost at about 700, which is an extreme increase from previous years. But we also know that clinical placement will be strained in the fall due to hospital constraints for hosting the placements themselves. So we know that we're going to have to get creative. We have a myriad of innovative best practice initiatives happening around the state. We have our career and technical education centers are offering health-related courses in 12 out of their 17 locations. We have 3 area health education centers supporting pathways to increase the supply, the distribution, and education of Vermont's health workforce. We have apprenticeship and workforce expansion pilots happening through the Vermont Department of Labor. Nursing pipeline programs are stood up at nearly every hospital across the state. We have an immense infusion of workforce initiatives through the Rural Health Transformation Program currently being implemented. And we have a healthcare workforce collaborative, and these are just to name a few of the wonderful initiatives that are currently happening throughout the state. With such a robust starting point and what was and has been an engaged advisor group, it has been quite easy to update the plan. We began the work grounding ourselves by establishing a charter, a mission, a vision, and values. The Healthcare Workforce Strategic Plan Advisory Committee offers ongoing evaluation and innovative program design and consultation on healthcare workforce. We convene quarterly and hold an annual in-person meeting to review and refresh our mission, vision, values, and our initiatives. We created our mission to champion a sustainable healthcare workforce for Vermont, with a vision of a stable and adaptable healthcare workforce that evolves to meet the state's changing needs and that promotes the health and well-being of every Vermonter. I'm going to read for you our value statement because I think it's well written and really culminates the product that we've created. Emphasizing psychological safety, a person-centered focus, integrity, and accountability, we are committed to supporting and growing the well-being of Vermont's healthcare workforce. Guided by the expertise of those actively involved in Vermont's healthcare workforce development, we use evidence-based decision-making and promote the challenges of Vermont's healthcare workforce. We believe in the strength of collaboration and teamwork, seeking to solicit input and coordinate efforts across the spectrum of the healthcare system. We prioritized 3 areas of focus in our work, centered around retention, job satisfaction, and overall well-being, scaling pathway and recruitment programs, and creating long-term strategy while advancing the collection of data. Each of the goals that we established, which I mentioned are 3, have 3 associated strategic initiatives and measures associated with it. For retention, job satisfaction, and well-being, we will work on a plan to assess job satisfaction across the state and continuum of care. Already underway are employee development initiatives, not only across the state already, but through the Rural Health Transformation Program. We also have efforts underway to reduce barriers to workforce in relation to the work of the Rural Health Transformation Program. Taking just a little step back, we had the first draft available when the Rural Health Transformation Program first set out to get applications from states. So it was a really great way to help inform that program. So our expected outcomes for goal number 1 for job satisfaction, well-being, and retention would be to reduce turnover and vacancies through our initiatives, improve workplace satisfaction, and improve the number of people staying in healthcare. Our second goal pertains to pathways, recruitment, and long-term strategy. We seek to identify and support scalable pathways. We aim to improve the awareness of programs, pathways, and resources. And we aim to continuously evolve our plan over time. We'll increase enrollment and graduation rates, increase the number of skilled healthcare workers through these efforts, and increase the training and employment opportunities around the state. Our third goal is around further advancing our data collection and analysis. Workforce pipeline evaluation will further identify gaps in our system. Analysis, problem solving, and decision making will use our data to drive workforce strategies and our priorities. And we're going to evaluate and benchmark all of the wonderful work that we have just discussed here through our data collection. The Office of Healthcare Reform will use data to track successes and challenges of our solutions by supplying an annual report. Improved data quality and accessibility is our goal or our expected outcome. Enhanced ability to identify trends and opportunities, and to increase the efficiency and effectiveness through the strategic use of data and insights. There was a pretty rigorous planning process for this particular project. It was quite exciting as I started in June of 2024. The Oliver Wyman community meetings were taking place, so it provided ample opportunity to connect with the communities, which was exciting. But we'll talk a little bit about the process. So again, as I mentioned earlier, it was a collaborative effort led by myself and informed by the state of Vermont. But other key information was synthesized through interviews that I had with members by attending the Oliver Wyman community meetings and speaking with our community members. We monitor a fair amount of grants, so reports from the nursing pipeline grants and preceptor grants and employee assistant or employee incentive programs were instrumental in helping to identify and glean information for the plan. I sit on other related state work groups, so that information also helped identify where the programs were headed. Used related state plans like the SHIP and reports, connected with providers and attended conferences throughout the time period. This is simply a snapshot of the process that started in, well, as I mentioned, I started in June, but there was a little bit of an onboarding process there. So we start in July really thinking about level setting and having those advisory member interviews. Concurrently, the data center was working with the Friedman Healthcare group to identify how we want to move forward with our supply demand modeling system for our data center. So those reports were coming out, and that's when the Oliver Wyman meetings were happening. In November, December of 2024, we started to really dig into our core purpose as a group, spending January through the spring, further identifying our mission, our vision, values, workshopping, new incentives, and continuing our efforts on values, charter, and challenge statements. One thing I want to note is that in my past, I've done a significant amount of strategic planning for large organizations, but coming into Vermont and the state of Vermont's system of how they do things, I participated in some continued learning and the LINK programs through the state of Vermont to line up the strategic planning efforts that I was working through with the state best practice. So all along this continuum, I was participating in strategic planning processes that were consistent with state of Vermont. Through the summer of 2025, we came out with our first draft of the plan after a half-day work group session with the Strategic Plan Advisory Committee, where we delved deeply into the initiatives themselves. After that, the Rural Health Transformation Program was announced, And lo and behold, we had this first draft, which was fantastic. And since we have, we talked about it being an iterative, phased approach, sought after comments from the public, from departments throughout the state of Vermont, different agencies throughout the state of Vermont, updated it to fit in nicely with Act 68 as well, and started to farm that out to leadership for approval. As I mentioned, taking part in some of the continued education here at the state of Vermont, I identified some of the best practices that the state uses in strategic planning. And these were the methods I used to gather and synthesize information along the way. Most notably, the opportunity scoring at the end really helped us decide which initiatives were going to be the most suitable for us. Implementation and next steps. Strategic planning is nothing without strategic implementation. Built into the plan itself, there's implementation processes, steps, and how the workforce strategic plan group wanted to move forward. There's also a separate project management infrastructure in place and ready to implement. However, implementation has been operating concurrently alongside this work because there are other related work streams really happening and moving along the way, and a lot of cross-agency collaboration. As I mentioned, there's the Health Workforce Data Center supply demand modeling scope of work underway. We aligned this work with the Rural Health Transformation Plan. There's plenty of work happening through our health professions, shortage areas, and oral health needs. The DSU has a beautiful workforce website that they've been designing. So a lot of work happening concurrently, but really looking forward to delving more deeply into our initiatives themselves. Our next steps really is to continue the work across the rural health transformation projects, using that in which we learn to help continue our process. It's integration into the healthcare delivery strategic plan. It's expanded, the expanded inventory, and gap analysis to span the care transformation. So as many of you know, on the Green Mountain Care Board, we started an exercise in the spring to inventory all the work happening around the state. And that actually helped feed an inventory I had started for workforce specific initiatives happening not only within the state of Vermont, but within all the organizations across the state. So I have a preliminary gap analysis that's going to continue to help move the needle forward for us. Next steps are to establish regular updates to the board. We want to work with the Green Mountain Care Board to fill a vacant GMCB Primary Care Advisory Group seat on the advisory committee, and to have a half-day workshop in August to continue our work and hopefully start the implementation process once we do hear back from you all. In closing, I want to, just touch back on the fact that this current plan is a foundational roadmap setting the stage for more comprehensive healthcare delivery strategic planning to come. It builds on extensive stakeholder engagement and the substantial workforce initiatives already underway, including those of the Rural Health Transformation Program. And as I mentioned about our inventory and it identifying some preliminary gaps, it suggests that our opportunity here for long-term sustainability and greater access to care lies not only in expanding our programs, but in building a cross-sector centralized workforce infrastructure designed to support the greater workforce ecosystem. Continuing this work is exciting, and I look forward to doing it. And I wanted to open things up for discussion and questions.
Can I make a comment, Suzanne?
Please.
Thanks. I just wanted to thank Suzanne for her incredible work on this. I have actually been on both sides of this process. I was working for providers when this process began, and I got to see Suzanne in action as a member of this advisory group, and have then continued to be able to work with her as we develop the rural health transformation application to CMS and other things. And she's really just done a tremendous job and has really worked incredibly independently and productively and collaboratively with the provider and education community. So I just really want to commend her and say that publicly, that I how much I appreciate the work that she's done.
Thanks, Jill.
Thank you.
Questions?
Thank you very. Yeah, I'll go ahead. I'll open up to the board members. I have no order, so whoever would like to jump in with any discussion points or questions, please go ahead.
Chair Foster, this is Sarah Teachout. I'll jump in if that's okay.
Please.
So I appreciate the work that you've done here, and like Jill, I was involved actually in the original legislation that created this effort. So I appreciate what you've done here. One thing that came across my radar recently that I just want to bring to yours, as you know, this sounds like an evolving process and things that you'll add to. There was a really interesting Milliman study on, and I can share it with you later, how we use our graduate medical education dollars to develop our provider workforce. So I just want to raise that. If you haven't seen it, you probably already have, and ask you to consider that as you go forward with your work. So other than that, I don't have anything to add. Thank you.
Thanks.
Thanks, Sarah. And yes, please do share it. I'd love to see it.
This is Dave. I can pop up. Sorry, Tom. Sorry. Yep. Just a few questions. So thank you so much for the presentation. I guess my area of interest to ask about is similar to Sarah's line of questioning, which is about the provider workforce. When I reviewed the documents, it seemed largely focused, and I think totally appropriately, on the non-provider healthcare workforce in Vermont, which we significantly need some strengthening of as far as quantity. I did notice that you, in the timeline, show the Maple Mountain Consortium, but then I was trying to figure out other provider workforce initiatives. What have you thought about with provider workforce initiatives? And then also sort of try to understand how to prioritize those areas of need for the provider workforce. I think this might piggyback a little bit into some of the other reform work of defining essential services and areas. But if you could expand sort of on your initiatives to improve the physician, APRN, PA workforce, especially within the areas of essential service needs in Vermont.
Yeah, thanks for the question. So it sounds like, yeah, it feels like there's more work to do there. And I think one of the challenges that we have right now is it's pretty limited with the rural health transformation dollars in terms of what we can do around physician, things like loan repayment. Some of those strategies we've used in the past, we can't use those dollars for. So I think that there is more work to do here, and also something to work on with our partners at Bi-State, we've got with Vermont Medical Society. I feel like we should take this back to make sure we've really covered this. I don't know, Suzanne, if you have particular comments on this right now.
I do. So a recent study that the Vermont Department of Health released does tie back to provider retention that I think will help us tell the story as we continue to move that needle forward through the loan repayment programs and its success thus far. So if you would like, I can share the link to that latest 10-year study showing the retention rates. So really telling the story is going to be some of the next steps when it comes to provider. Our data analysis team will start to understand better our supply and demand focus, and that will help tell the story and the need and show the need. So we will take this back, but I wanted to tie back some of the great work that the Vermont Department of Health has done in tracking the loan repayments and the success stories thus far.
One thing I would just sort of like to add to the conversation is that, we do spend a lot of money on Vermont in our academic medical center. And I think that's really important to have a strong provider workforce in Vermont, and that has been the pipeline. But sort of how to think about that as, that's a lot of money. So we need to think about if that money's being used in the most ideal way for the workforce needs of the community of which the University of Vermont Medical Center serves. So I think it's something to think about as we think through our workforce needs and development and, the trade-offs that we have to make implicit in those decisions.
Thank you. Yeah, and as I think we've already said, this is an evolving plan. It's something we keep updating. So I really appreciate your thoughts and feedback, and also look forward to having that representative of that physician group added to the plan, to the advisory committee. So thank you for the comments and thoughts.
Tom, were you going to go?
Sure.
Yeah, go
I'll
ahead.
ahead and thanks, Jess. And thank you, Suzanne and Jill, for the excellent presentation and just the amount of work put into this and trying to study these problems. They're difficult. And the thing that I took away most from the presentation today was actually goal 3 that Suzanne went over, the thoughts about further evaluation. And one of the areas the 2 areas that I really, I think will be important to pay attention to over time. When it comes to workforce, the workforce is crucial for 2 reasons: an access issue for patients, but also the well-being of the workforce. And there can be, I think, 2 types of problems for access or workforce health. You can have a numerical shortage of providers. There's just too few. But there can also be functional problems. And that distinction matters because the remedy is different, right? If there's too few of a certain type of providers or too few of a certain type of workforce, then you need more training, more recruitment, loan repayment, things like that. But if the problem's functional, just adding more doesn't fix it. It actually can make it worse. And so identifying what type of problem it is, numerical or functional, becomes important. And if it's functional, we want to think about scheduling reform, panel management, bottlenecks, how to remove the bottlenecks or what needs to happen for that. So the remedies are different. And I think there's obviously both happening in our state right now, and trying to figure out a way to monitor what's happening, to make that distinction and align the remedy with the problem is going to be a large task. And I think that's going to be dependent on goal 3 from the presentation. The other area that I think that comes to mind when reviewing all the material that was shared with us is how the workforce efforts and the resulting changes impact affordability. We have an affordability issue across the state, and increasing workforce is the largest expense. So how to find that balance, I think, is something I don't have an answer to. but I think is something to try to pay attention to as we move forward.
In goal number 2, in that vein, I made sure to put in responding intentionally to demand, right? And this is where you're coming from with both of those statements. It's not just about increasing numbers of people in the seats. It is understanding that telemedicine, e-consults, some of the programs through the RHTP, that they may not specifically say workforce, but they are addressing some of the 2021 initiatives that were in the plan originally. So we were able to tick off some of those boxes from the past strategic plan based on some of the rural health transformation programs. Those are some removing those barriers to workforce, right? It's the constraints and the burden. And then allowing folks to operate at the top of their licensure. So it is a fine line of marrying supply versus that true demand and other ways in which we can meet the demand. So I appreciate that sentiment and know that I think wholeheartedly about that as we continue our efforts.
I would also add, those are great points, Suzanne. I would also just add that, sometimes what we're trying to do is reduce, say, contracted labor versus full-time staff. So really trying to reduce those traveler contracts for nursing and really other professions now. So that I think actually does make things more affordable. The other piece is that we have shortages in areas like long-term care, home health, other parts of the system, where I think if we were stronger in other parts of the system, we might be able to do a better job at preventing some of the more expensive care. So I think that it's not really just a more question. There's also a sort of how is it deployed and where is the support.
One thing when she talks about the long-term care, one initiative, when I said there's related work streams happening concurrently, Dale, the Department of Disabilities, Aging and Independent Living, we're working together on a direct care workforce strategy as well. And that's taking the burden off the need for added providers when we have folks that can go into the home and provide that direct care. So we have a subgroup working on how we increase the numbers since we are an aging population. Things of that nature, and then hopefully take care of me very shortly.
I got a ways to go.
For these achy bones, I don't know.
Yeah. That's a good reason for us all to be extra concerned, right? Yeah, no, I appreciate that response, and I think that as I read through all of the documents, it's impressive, and I appreciate the work you're doing. I think it'll be a continued challenge to try to align the remedy with the problem, right? Where more isn't always going to be the answer. Removing barriers, removing bottlenecks, improving culture, those things are sometimes more important and necessary. And when they're overlooked, just adding more can make them worse. So,
sometimes simply a great communication plan can help in a lot of ways. Thinking about the immense work that we're already doing across the state and how we really pull that together. And I'll say that the Vermont Department of Labor is working hard, and we're working together. We meet on a regular basis to make sure that we're in line sync as well.
Thank you for your time today, and thank you for what you do.
Thanks so much. Thanks for the thoughtful read of the plan.
Yeah, I just want to add my congratulations on pulling together a lot of different, brainstorming efforts and stakeholders to pull together something that's really going to be very challenging and has been really challenging for our state for a while. So there's a lot of really important work here, and I just want to express my sincere, gratitude for that work. a question, as I think Suzanne, you alluded to, implementation is often, the hardest part, right? It's where all brilliant strategic plans die, fail. And I'm
Yes.
just wondering, as you're thinking about that, because it's great to have the goals and the success metrics and all those, and they seem spot on here. I really appreciated them and the work behind them. I just wondered if you could talk a little bit about, the process to assign some high level kind of buck stops here level accountability for meeting each goal, and also the process for assigning more ground level operational responsibility for ensuring the follow through of the goals and meeting those outcomes. Just a little bit, if you could talk a bit about that.
Do you want me to start?
I look forward to, rolling up my sleeves is really, my answer right now. As we continue, once approved, really digging into what that looks like on the ground will be important. But I will say that I have an interagency group that's already underway across the different agencies. So we have personnel that are already doing some of this great work. It's really coming together and aligning it and finding those champions, which I already have. It's just, rolling up the sleeves and getting us all around the same table. Hopefully very soon. So, but you might have.
No, I think that's a great answer. And I think, the other piece is, of course, some of the work here is really work that is being done by different organizations on a voluntary basis. We don't have levers for all the things that we want to do. But what I think has been incredibly helpful about having the plan, even the draft plan that we had, was when an opportunity like, say, rural health transformation came along, and we knew workforce was one of the things that could be funded. We had a list already. We had already done a tremendous amount of stakeholder work, or Suzanne had done a tremendous amount of stakeholder work, and we were ready to pull ideas and plug them into the plan. So I think part of having, this kind of plan on the table is we may not be able to further everything all at once, but it makes us more ready to seize opportunities and to move things forward. So yeah, I think more work to do on the how, for sure. The how is always the hard part.
It's always the hard part.
What is so much easier.
I did, however, write down my steps in my head as I was writing the plan, so that it wasn't just simply, here we're going to do this, but here's how we're going to do it. So that's a big piece of the plan itself. It has the implementation built right in. And like I said, I'm ready.
As long as you, I was just gonna say, as long as you feel like the stakeholders that you've engaged in this whole process are willing to be the who is going to implement this plan, and they are identifying these are goals that are actually feasible and can be implemented, and they're willing to do it and sign their names to it. I think that actually makes this feel like it actually may come to fruition versus lofty goals that we hope that somebody will implement at some point.
Yeah, I mean, honestly, most of them were a part of the process. So yes.
Yeah, that was really done closely with the key organizations. I think, one of the things that part of how this strategic plan came into being at all was, I remember, because I've been around a while, a time when we would just sort of like get reinvigorated and interested in workforce, say every 5 years, and there would be sort of like some kind of like panel convened and created that would kind of start over. And so one of the things that at the time when this was created, and I think this was right, is we really wanted it to be an ongoing process, so that there was a strategic plan in place, regularly being updated, a group being regularly convened, because we didn't really see a time when we would want to take our eye off the ball of how do we further our work, our efforts to reduce our workforce challenges. So I think it's really helpful that we have something that's built and in place and has structure to it that doesn't come in and out of people paying attention to the concern.
Right. Well, my second, and actually my last question, is just really thinking about connecting AHS's two streams of work, actually, that are topics of today, right? The workforce strategic planning and hospital transformation work. And as I think about specifically, as hospitals are facing, these financial pressures, we've seen UVM, laying off workforce. We're seeing hospitals eliminate and reduce service lines. We could look at Copley, we could look at Rutland, we can look at Brattleboro now. And one of the things I would love to see in the plan is some strategic effort to proactively keep downsized workforce here in Vermont generally, right? So we've got some downsizing happening. How do we prevent those downsized workforce from leaving the state when there may be needs that could be met within the state? And so being proactive about that and having a plan of action for that, I think would be really helpful. So we don't have to keep, trying to look to other vehicles or other means, loan repayment and other such strategies to recruit workforce when we may actually have the workforce here, but they could be redeployed. So just wanted to put mention there and ask if that's part of some of your thinking as those two streams of work are happening simultaneously.
Yeah, no, I think that makes a lot of sense. I'm not sure I would want to represent that. I'm looking at Katie across the room. You can't see her. If we've done that explicitly, so that's something we can talk about as a team.
We
Yeah.
also, when was it? I think we were all pretty concerned when downsizing started to become a thing and making mention of that. And one of the meetings at the Strategic Advisory Committee meetings, we addressed it and came up with statements to help that organizations support their staff and create proactive plans. So it was a communication plan that like VAWS and VACA and, all of the and VNAs were able to take back to their organizations and support their organizations with to help make sure that they had proactive plans in place to keeping the workforce in Vermont. It was a basic statement, but yes, it is on the back of our minds. And as we continue to work collaboratively within the state and within the office, we'll continue to focus on that.
Yeah, it's a great point.
I would just love that because these are people who have already chosen Vermont
Right.
to live and work. And so if we can retain them and find opportunities and create those pathways so they don't have to look too hard to find a job at a different hospital or at a different organization, I think we'll have a better chance of retaining those valued employees in our state. So
Great.
That's it.
Great
Thank you.
suggestion. Thank you so much.
Thank you. Any public comment at this time?
Just super brief comment. I just wanted to thank the team for all the work that they did and are going to do. And I'd be remiss if I didn't put in a plug for loan repayment and scholarship. Just one thing I do is I mentor students, graduate and undergraduates, and I don't think that Vermont candidly is ever going to compete on salary with a lot of the population centers in big cities and management consulting firms that work in those places. But I think we can compete on these other areas. So I just want to continue to support the work that you guys are already doing. So thank you.
Thanks.
Thanks.
Ms. Wasserman?
Yes, thank you. Suzanne, you've done a tremendous amount of work. I worked in state government for many, many years, and I know what it took to pull this together. So I want to thank you for all that incredible work and the collaboration. Very, very comprehensive and challenging. I do have some comments. It appears that the AHS workforce plan seems heavy on process, but a little weaker on implementation. And the plan nicely lays out goals, strategies, and outcomes, but the generalities leave one wondering what exactly will be done and when. And it would be nice if there were some definitive dates or a timeline which would provide some accountability for all of these things that need to be done. I guess the essential question is, will this plan give us the outcomes we need? And if not, can the plan be amended to give us what is most needed? It's concerning that the AHS work plan makes no mention of our dire shortage of primary care physicians. As we all know, primary care physicians are the foundation of our healthcare workforce. And this is the workforce plan for the state. The first page of the workforce plan highlights AHS's legislative charge, quote, increase the supply of primary care providers in Vermont. Yet AHS makes no mention of primary care physicians, not one. So I searched both the AHS work plan and today's slide deck, and the words primary care physician are nowhere to be found. Additionally, the plan covers the 3-year period, 2026 to 2028. And so this absence that I'm referring to, does it mean that this absence will delay addressing our primary care physician shortage for another 3 years? That's a question I have. Furthermore, the plan makes no mention of the all-important Primary Care Steering Committee, which was created by the legislature to inform the work of state government. And one of the steering committees, the Primary Care Steering Committee, one of the steering committee's top mandates is the recruitment and retention of primary care providers. Shouldn't primary care physicians be a prominent aspect of this workforce plan? We do not need to gather data on this issue to determine whether it deserves attention. Here, I'm referring to the plan's emphasis on identifying workforce gaps. I don't think we need more information or data on whether or not there's a problem with primary care physicians. So the question is, why is a direct reference to recruitment and retention of primary care physicians missing from this work plan? It's the most important element in improving access to primary care, especially in rural Vermont. During this recent legislative session, the House Healthcare Committee held a public hearing on how to improve access to primary care. And in that process, I submitted a list of ideas on how to recruit and retain primary care physicians. None of the 16 ideas that I put forth are costly to implement. And Daisy Berbecco, who's the vice chair of the committee, described them as many simple but very sensible recommendations. I also shared this list of ideas with the AHS Rural Health Transformation Team back in April. I asked AHS to merely develop a plan for the recruitment and retention of primary care physicians, since none exists. Surely there is a small amount of money in the $200 million rural health grant to develop such a plan. Unfortunately, I received no response. It would be easy to create a PCP recruitment and retention plan, since a lot of the work has already been done. And once a plan exists, legislators and others could prioritize its implementation. But we need a plan. By the way, I also asked AHS to post this list of PCP recruitment and retention ideas on their website, which actually invites public comment. But again, no response. AHS does not post public comment. So I'm formally submitting to the Green Mountain Care Board this list of 16 ideas on how to recruit and retain primary care physicians. To conclude, Vermont's workforce plan needs to include the development of a plan. My question for AHS is, why are you ignoring one of the most critical challenges facing our workforce and one that needs immediate attention? My request is that the AHS work plan be amended to specifically address Vermont's dire shortage of primary care physicians, especially in rural areas. Thank you.
Chair Foster, I just wanted to make a comment about primary care since it's come up a few times, if that's all right. Do you want me to do that after the end of the public comment? What's helpful?
No, now's great.
Okay, great. So I really appreciate the comments. I think one of the things that this is making me realize is that we actually have we have a tremendous amount of work actually going on around supporting primary care, the work that we're doing on the blueprint, dollars investing in primary care as part of the rural health transformation in our blueprint modernization efforts. And it's not really, I think it's not really integrated into the workforce plan in a way that, so it's disparate. It's another sort of path of work that we're actually spending a tremendous amount of time and energy on, but it's not integrated. So I just appreciate the thinking about that and want to just say to the board that we will try to bring those. That's something we can bring together because it's certainly something we take very seriously and are spending tremendous amount of energy on right now. So, and we do have that primary care workforce steering committee that Dr. Saroyan is part of. So I think we just need to kind of make that part clear in this work. Glad to do that.
Thank you very much, Jill. Walter?
Thanks, Owen. Jessica spoke to a lot of my concerns about this plan, but I just wanted to address one issue that I didn't hear. And I come to this as probably one of the only ones in this meeting who's actually out on the front lines in the mud of the trenches as what's called a member of the working class. I'm 70 years old and still working full time. I didn't hear anything about salaries, benefits, all that kind of stuff, because that in itself is what's going to retain workforce development here. You know, you're constantly, Vermont's too expensive to live in, they're not paid enough, and they're not given benefits. I hear comments about how travelers come in so they can break the unions, all that kind of stuff. So I'm wondering about the specifics that matter so much to people who are actually out in the front lines. You know, what are they being paid? Are they going to be able to retire? Those sort of questions. And I didn't hear any of that in the generalities in the presentation. And that's going to be your biggest issue right there.
Great. Thank you for your comment, Walter. I think it's well taken. Any other public comment at this time? Suzanne, thank you very much for your presentation. It was nice to see you, and thanks for walking us through this. Great.
My pleasure. Thank you so much.
Our next agenda item is an update from AHS on hospital transformation, which will be presented by Ms. Olson and Katie Carroll. I'll turn it to you, Ms. Olson. One question I had in the beginning was whether or not you have any information or slides that you'd like to provide as an overview in a public session. I understand there's concern about potential need for an executive session, so I just wanted to start with whether there's anything for the public session.
There's not anything for the public session. We have done several presentations on the on transformation in the legislature, so there are links available. We're certainly, if it's helpful to make those available on a different format or in that format to you as for you to post or those links, we're glad to do that, but we're not presenting anything new in the public space today.
Great. I have a couple of questions to allow the board to evaluate whether or not an executive session would be appropriate. And the first is whether or not sharing potential transformation plans from specific hospitals would place the hospitals at a substantial competitive disadvantage with respect to contracts and labor agreements and relate to trade secrets that are exempt from public inspection and disclosure under the Public Records Act.
Yes.
And in your opinion, can these plans be shared publicly without disadvantaging the hospitals?
No, I just want to clarify, there are parts of those plans that have been shared publicly, and there are elements of items that are protected under public records right now, under the new Act 146, as just passed, that is the focus of our conversation today.
Understood. Given that, I move to make a finding that premature general public knowledge of hospitals' potential transformation plans with respect to contracts and labor relations agreements and in connection with trade secrets would clearly place those hospitals at a substantial disadvantage with respect to contracts and labor relations agreements.
Are you looking for a second?
I'm sorry,
Second.
there is a second?
Yes.
Great, okay. And all those in favor of the motion, please say aye.
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 Aye. Motion carries. I also move that we enter into executive session pursuant to 1 VSA 313A1 and A6 for the purpose of discussing hospital-specific transformation plans that are exempt from Public Records Act. Attendance at the executive session will include the board members, council, necessary Green Mountain Care Board staff, and AHS representatives.
Second.
All those in favor say aye.
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 Aye, and the motion carries. One question for you, Ms. Olson and Ms. Carroll, about how long do you think your overview of the transformation plans, do you think it'll take?
I'm expecting that this will be a very short conversation, maybe 15 minutes.
Okay, so why don't we may have questions. Why don't we plan for 40 minutes, just in case. And for the public who's attending, we have one last substantive agenda item after this, but we will take a break from this session. We'll go to executive session, and around 12:50, 12:45, I expect we'll be back, maybe sooner. So with that, we can take a break, and the board and AHS will move to executive session. Thank you.
Thank you.
Do you guys want?
Yeah, I'll join from mine. I'll join it from mine, and then
All right, we can resume our hearing of July 8th. We have one last presentation, and it's our Data Governance Council Submitter Communication Standard Operating Procedure and a potential vote. And I'll turn it over to our counsel, Julia Korelman and Ravi Lalla, for the updated presentation.
Thank you, Chair Foster, and thank you, members of the board. My name is Ravi Lalla. I'm the Director of Operations, for the data team at the GMCB. Today I'm here to present, the new standard operating procedure for the submitter communication and request a vote. Before I present the information, I would like to take a minute to thank Julia Korelman and Kristen Lajenis, who helped tremendously behind the scenes in putting it together, all the information and all the processes and so on and so forth. So now let's going into the presentation. So I have broken down the presentation into the recap, the purpose, the public comments that we have received, and finally the potential motion language. So moving on, just to recap from what we have seen on May 27. On May 27, we presented our standard operating procedure to the board for submitter communication. Specifically, there were three components, with respect to registration, data submission, and annual attestation. And the standard operating procedure talks about the process for each of these three submissions and registration. So essentially, this is a significant milestone in the overall process of data governance modernization for the data team. Specifically, it will standardize the communication with the submitters, and it will help us improve the efficiencies on the data operations. Moving on to the next one, the purpose of the meeting today is to present, the SOP as it was discussed on May 27 and request a potential vote. And then moving on to the public comments, like in the last 30 days since May 27, we have not received any public comments on this request. And then finally, the potential motion language. Chair Foster, I would like to turn it back to you on this one.
Great. I'll make the motion, then we can see if there's any discussion or comment. But I move to adopt the submitter communications procedure. And Ravi, I think you're... I move to adopt the submitter communications procedure as presented on May 27th, 2026, with modifications discussed on July 8th, if any. Let me back up. Let me just start here. Is there any modifications any of the board members would like? Okay.
No.
Then I move to adopt the submitter communications procedure as presented on May 27th, 2026.
Second. Also.
Okay. Any comment or discussion? Any comment from the healthcare advocate? Any public comment? Great. Then all those in favor of the motion, please say aye.
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 Aye. And the motion is approved.
Thank you very much, Chair Foster and board members. Thank you very much. And here is some information for further contact.
Great. Ravi, thank you very much too. And thank you, Julia, for helping us work through this. There's nothing else on the agenda for today, so I'll ask if there's any other old or new business for the board. And I will move to adjourn.
Second.
All in favor, say aye.
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 Aye. And we're adjourned. Have a good afternoon.